hair hickory test or complete water deprivation test or WDT. This is a little strenuous and dangerous test too. The patient has to be admitted under careful supervision of an experienced person, particularly in conducting this test. And as per the protocol, all the details have to be followed. Indication for doing this test, it is to differentiate between central diabetes insipidus and nephrogenic diabetes insipidus, not in other cases of polyuria. Only when we come to a conclusion as per the previous algorithm that we are probably dealing with CDI or NDI, then we may require to do a WDT. The technique here is complete deprivation of fluid for 24 hours or injection of hypertonic saline or hypertonic sodium chloride intravenously and injection of DDAVP exogenously in measured doses and measurement of plasma ADH to serum osmolality ratio. So, the interpretation of this plasma ADH to serum osmolality ratio has to be done as follows. Decreased ratio occurs in central diabetes insipidus, there will be an increase in the ratio in nephrogenic diabetes insipidus. In other words, the test will not be positive in nephrogenic diabetes insipidus, the test will be positive in central diabetes insipidus. No response in NDI and positive response in CDI. So, remember, this is a specialized test and not in the purview of us, but the indications, technique, if we know it is adequate, and such patients have to be referred for qualified people like endocrinologists who do this test and give the interpretation for us. Few words about nocturnal polyuria. NP or nocturnal polyuria is a circadian rhythm disorder of the secretion of AVP. Normally, during the course of the day, the secretion of ADH will be occurring into the plasma from the posterior pituitary. During the night time, there is no secretion of ADH at all from the posterior pituitary and it is brought to 0 picograms per ml of plasma. This is to avoid urination during the night. That is why we don't urinate during the night time. We urinate around 4 to 5 times during the day. But once we go to bed, we don't get up again to urinate. This is what is called a circadian rhythm. This circadian rhythm is due to the coordination of the melanocyte stimulating hormone from the pituitary gland and the ADH. The melanocyte stimulating hormone secretes a substance called melatonin. This melatonin controls the sleep cycle or the day-night cycle or circadian rhythm. So, once the pituitary knows that the patient is sleeping due to the information that he gets from melatonin, it suppresses the secretion of ADH and no diuresis or urine output occurs to a greater extent during the night. Only around 250 to 300 ml of urine is secreted during the whole night, which we excrete in the next morning. Whereas in the daytime, the ADH secretion is there is diuresis, there is water loss, there is urine output, around 1.1 to 1.5 liters of urine is produced whole during the day. Whereas nocturnal polyuria is a disturbance of this circadian rhythm. So much so, the AVP or the ADH is continuing to be secreted during the night time also. So, there is urine production in the night, more and more urine is produced and patient has to get up either once or twice or thrice to empty the bladder, and this is what is called nocturnal polyuria. This can also be due to an abnormal increase in atrial natriuretic peptide and brain natriuretic peptide. When there is an increase in the natriuretic peptides, particularly during the lying down position in the night, the ANP and BNP values will go up. In patients with heart failure and cirrhosis, in patients who have a stretch of the atrial musculature, this increase in the ANP causes natriuresis or excretion of excess sodium. This excess sodium is followed by water, and that results in nocturnal polyuria. So, how to diagnose this condition? Measurement of plasma AVP and urinary AVP. Urinary arginine vasopressin levels and plasma arginine vasopressin levels are measured. The urine AVP to urine creatinine ratio is done in a good lab, and this is a good lab test to approximate the plasma AVP test. We can avoid doing plasma AVP. Instead, we can do a urine AVP and urine creatinine and to pick up patients of nocturnal polyuria. So, this is all about nocturnal polyuria. Let us now look at the structural similarities between arginine vasopressin or the antidiuretic hormone, DDAVP, the synthetic analog, and the oxytocin, which is the other posterior pituitary hormone. You see here the arginine vasopressin, also called 8-arginine vasopressin, because it is in the 8th position. 1, 2, 3, 4, 5, 6, 7, 8. In the 8th position, we have got the arginine. This is L-arginine. So, the naturally occurring vasopressin or ADH is 8L-arginine vasopressin. The synthetic analog that is available commercially for treatment of diabetes insipidus is a D-arginine vasopressin. Instead of L-arginine, it is a dextroisomer of the arginine. It is in the 8th position, and it has also got a des-amino radical at the first position. So, this is the des-amino radical at the first position. That is why it is called 1-des-amino 8D-arginine vasopressin or DDAVP. Otherwise, structurally it is same as the naturally occurring vasopressin. The duration of action of DDAVP is much longer compared to this naturally occurring AVP. Look at oxytocin. Oxytocin and vasopressin are almost similar in their structure, except here instead of phenylalanine we have got leucine, and again instead of arginine we have got leucine. Except for these two differences in the amino acid sequence, the entire structure of oxytocin is the same as the synthetic naturally occurring arginine vasopressin. But we know oxytocin has got no action on the renal tubule. It has got the action on a pregnant uterus to initiate the contractions at the time of childbirth, and also on the mammary glands to initiate lactation. So, this is about the structure of the three similar hormones, two naturally occurring ones and the one synthetic DDAVP.